Welcome back, everybody, to our masterclass finale. Today, we're wrapping up with our clinical audit defense explainer, and we are setting a really sharp clinical tone right out of the gate. Why? Because we're looking at the absolute highest stakes imaginable in healthcare, real-time emergency cases, and the incredibly complex coding hierarchies that define them. Think about it. Whether we're dealing with an NSTEMI that's suddenly complicated by cardiogenic shock, an acute ischemic stroke requiring an immediate mechanical thrombectomy, or maybe a traumatic subdural hemorrhage complicated by a pulmonary embolism, capturing the full, exact clinical truth is absolutely vital for your audit defense.
Okay, let's dive into this. Here's our roadmap for the day. We're going to hit 1. Life-threatening red flags, 2. Cardiac crises and NSTEMI, 3. Neuroemergencies and stroke, 4. Respiratory failure and PE, 5. Core ICD coding hierarchies, and 6. We'll wrap it all up with our masterclass audit defense conclusion.
All right, jumping right into section 1, life-threatening clinical red flags, the clinical trigger.
Listen, to an auditor, clarity is literally everything. When we talk about a life-threatening acute condition, we're talking about an illness or injury that carries an immediate, undeniable risk of death or severe disability. It demands urgent intervention, intensive monitoring, and it is heavily marked by unstable vital signs. In the ED, this is a massively time-critical scenario. Any delay at all means survival becomes highly unlikely. When a hospital officially classifies a patient as being in critical condition, this is the precise clinical threshold they are crossing. Now get this, as surprising as it sounds, almost 30% of initial chart reviews actually lack the vital sign documentation necessary to definitively prove this critical threshold was ever even crossed. No way, right? But it happens every day. Put yourself in the shoes of a chief medical officer breaking down a triage chart for a second. These aren't just arbitrary numbers. These vitals actively signal the catastrophic failure of critical bodily systems. They're blaring red flags that guide priority resuscitation. If you look at circulation, severe hypotension, like a systolic blood pressure dropping under 90 or a heart rate skyrocketing over 150 beats per minute, those are massive red flags. For airway and breathing, if you see a respiratory rate tanking below 8 or shooting past 30, with oxygen saturation stubbornly refusing to climb past 90%, even with oxygen therapy, that demands immediate action. And neurologically speaking, a Glasgow Coma Scale score under 8 or witnessing status epilepticus dictates immediate life-saving interventions. Seeing these specific numbers explicitly written in the provider notes, that is your definitive bulletproof evidence of high clinical acuity. Moving right along to section 2, cardiac crises and NSTEMI. Let's visualize this crisis. Now, the exact physiological difference between a STEMI and an NSTEMI pretty much dictates everything in cardiology, and this brilliantly illustrates exactly why. With a STEMI, you have a complete total blockage of the coronary artery. That's what causes that very distinct ST elevation on an ECG. It requires an immediate drop-everything reperfusion strategy. But with an NSTEMI, the blockage is only partial, which gives us ST depression or a T-wave inversion. It's a hugely important diagnostic reality because it entirely shifts the immediate clinical pathway, and for us, it completely shifts the subsequent code selection. So, what does this all mean for your audit? Well, an NSTEMI is initially managed with medications, things like sublingual aspirin and nitroglycerin, though obviously they avoid the nitro if the patient is hypotensive. That's followed by an early invasive strategy. But here's the critical problem solution for your chart reviews. Picture this. You're reading a note where an NSTEMI patient's blood pressure just completely bottoms out, but the physician just hastily jots down hypotensive. You cannot just code hypotension. You have to query the physician to explicitly document cardiogenic shock due to pump failure, if that's what's actually happening clinically. Same goes if they develop a deep vein thrombosis, query it. Those secondary diagnoses absolutely must be queried, captured, and sequenced to reflect the true clinical complexity of the case and, of course, ensure accurate reimbursement. Okay, section 3, neuroemergencies and stroke, where time is quite literally brain. In acute ischemic strokes, a patient suffers a sudden loss of brain function because their brain cells are rapidly deprived of oxygen and glucose, which leads straight to cell death. But the actual mechanism behind it matters a lot. A thrombotic stroke happens when a blood clot forms locally, directly blocking the blood flow right there, within the brain. An embolic stroke, on the other hand, acts exactly like a missile. Fatty plaque or clot breaks away from somewhere else in the body, travels rapidly through the bloodstream to the brain, and blocks an artery there. These are distinct mechanisms, and auditors need to clearly distinguish them during chart reviews. Because time is brain, stroke treatment operates on a notoriously strict clinical timeline. Step 1 is thrombolytic therapy. That means using IV alteplase or tenecteplase to try and dissolve the clot, but this absolutely must be administered within a very tight 4.5-hour window. Now, if the patient misses that window, or if they're dealing with a large vessel occlusion, we look to Step 2, mechanical thrombectomy. This can actually be effective up to 24 hours after symptom onset. So as an auditor, your chart review is essentially an investigation of the clock. You have to verify these exact timestamps in the nursing flow sheets to validate the interventions being billed.
Now, what's really fascinating is how we handle those critical large vessel occlusions. There are two primary catheter-based clot removal methods at play here. First, there's catheter aspiration thrombectomy, where the blood clot is actively sucked out using suction. Then you have mechanical thrombectomy, where a tiny device is used to actually break the blood clot up into smaller pieces so it can be safely removed. Documenting these specific procedural details correctly is absolutely vital for your facility's case mix index. But what if the stroke isn't ischemic? What if it's hemorrhagic? Well, the coding protocols here are incredibly strict. Intracerebral hemorrhage, or ICH, is coded under category I-61. These codes require you to identify the specific location in the brain tissue itself, like the brainstem or the cerebellum. On the flip side, a subarachnoid hemorrhage, or SAH, which is coded under I-60, requires you to know the specific artery involved, like the middle cerebral artery or the anterior cerebral artery. Location and artery involvement, those are your definitive keys to accurate code selection here.
All right, on to Section 4, respiratory failure and PE. Let's talk capture and sequence. Picture this. A patient is admitted with a traumatic subdural hemorrhage. They become immobilized in the ICU, and out of nowhere, they develop a pulmonary embolism. Now, even though a PE originates in the circulatory system, it instantly triggers a respiratory emergency. When you're coding this crossover, you have to watch out for common pitfalls. For the PE, you must distinguish between I-26.0, which is PE with acute corporal mole, and I-26.9, which is without it. And for the resulting respiratory failure, you absolutely cannot rely on vague, unspecified terms. A huge pitfall auditors catch all the time is seeing a provider use fuzzy terminology or confusing the failure with ARDS. You've got to comb through those pulmonology consult notes to specify the exact acuity and type. Is it acute hypoxemic, coded as J96.01, or is it acute hypercarbic, coded as J96.02? Getting this wrong is not an option. You must sequence the underlying condition properly to reflect the clinical truth.
Which brings us to Section 5, Core ICD Coding Hierarchies. These are the absolute rules of defense.
So I want to pause for a second and pose a critical question to you, one that really defines the success or failure of a clinical audit defense. When you are looking at a highly complex patient profile, exactly how do we sequence acute versus chronic conditions? So, the crucial point really boils down to these core coding principles. First, you must code the primary acute life-threatening condition, whether that's an MI, sepsis, or a stroke, as the principal diagnosis. Why? Because it is the main reason for the admission. Second, when it comes to sequencing, acute always trumps chronic. There's only one strict exception. You only code the chronic condition first if it is the direct cause of the acute crisis. Finally, you must accurately identify the POA, or present on admission status. Did the condition exist at the exact moment of admission, or did it develop while they were in the hospital? Getting POA status wrong directly damages reimbursement, and it severely skews hospital quality reporting.
Finally, Section 6, our Masterclass Audit Defense Conclusion, the Golden Rule.
Documentation must be based on complete provider notes. No assumptions, no inference. Read it, remember it, and apply it every single day. Look, regardless of how blaring the clinical red flags are, regardless of if the vitals show severe hypotension and hypoxia, if the specific diagnosis is not explicitly written in ink by the physician, it simply cannot be coded. As an auditor, your entire defense relies on the written word. It doesn't rely on clinical guesswork, and it certainly doesn't rely on mind-reading the physician. If the chart is lacking, you don't assume, you send a clinical query. So, as you head back to your desks today and open up your very next medical record, I want you to ask yourself, are my chart reviews capturing the full clinical truth without any assumptions? Keep your clinical knowledge sharp, respect those coding hierarchies, and always let the documentation lead the way. Thank you so much for joining me for this explainer, Decode Healthcare with Harshal.